So welcome to the part 3 of our independent medical education video podcast. And the topic is simultaneous vision lenses. And I'm Dr. Andrea Janeková.
And I'm Francesco Carones. We have covered the diagnostics and digital tools. So now it's time to talk about the lenses itself.
In this episode, we'll look at how to select the right simultaneous vision IOL for each patient. And we'll cover the functional classification, lifestyle, profiling, and the strategies to reduce unwanted visual phenomena in our patients.
Let's start from the latest data from the 2024 ESCRS Clinical Trends Survey. When asked what type of presbyopia correcting IOL technology is used in the majority of your presbyopia correction patients, most surgeons said they use either trifocal or EDOF IOLs. These lenses are the backbone of modern presbyopia correction. But to truly balance both the quality and the range of vision, we need to tailor the choice of each individual patient. So, Andrea, why do you think that trifocal and EDOF lenses have become the leading choices for presbyopic correction?
The population is becoming presbyopic. The patients are searching for some solution to be the glasses independent. And so that's why the trifocal lens or even the EDOF lens can bring them the better vision and better quality life, because the patients and generally the people are becoming more active even in the higher age. And also the intermediate distance become very much important in our lives. The car dashboards, laptops, and the smartphones, we spend hours a day sometimes. And this is something which makes us life literally living in the intermediate.
Right, and the previous generation of multifocal IOLs, like the bifocals, were leading these patients with the gap of an intermediate. It has become more and more critical as digitalization is ongoing.
Let's start with how we classify patients and match their daily needs to the right IOL design.
Starting from the point of view that the more range of vision you're going to provide the patients, the happier they will be. We in our practice start from the concept that consider a patient as a good candidate for the widest range of focus unless proven differently. What is going to prove something different? First of all, ocular conditions, but excluding ocular condition is what the patient wants. Because for those who are addicted to near vision, putting a lens that does not allow to get that distance is going to be detrimental to them. As well as for those who are eventually driving for a long time at night, they would not be happy at all if they end up with some sort of intolerant, not possible to be tolerated night dysphotopsia.
The patients who are working as a driver is a special category, and we are very happy to having the EDOF lenses, and that we can offer them even the intermediate vision and social reading for these specific patients. Can you share a case where using the functional classification helped you choose a lens that was a perfect fit for the patient's lifestyle?
Yes, what I like about the classification that we are using currently is that it is really something that you can reproduce with your hands. So this is something that I do on a routine basis with my patients. Here is a monofocal IOL, here is an enhanced monofocal, here is an increased range of focus, here is a full range of focus. And the more we go in the depth of focus, the more we are going to take a chance as regards quality of vision and night dysphotopsia. So if you need the full range of focus, you may have more likelihood to be a little bit unsatisfied as regards the quality of vision at night or having all that it is related to Starbucks and we know what. Even with the right classification, managing expectations and communication is key to the long-term success. So, Andrea, how do you prepare patients for the adaptation period after simultaneous vision IOL implantation?
So I really need to talk to the patients, or my team. Everyone is trained to talk in a very similar way, that we encourage them that even there will be some fatigue phenomenon at the beginning, it will improve in majority of the patients, and in long-term results they will be probably satisfied with their vision. I explain, even during the surgery, when I implant the lens, I tell them, you maybe already see the circles, the design of your new trifocal lens, as when the kids are teaching how to read the sentences, that he need to also teach his brain how to read with the new lens.
Yeah, I almost stopped about talking about neuroadaptation and telling the patients you will see this photopsia decrease and eventually disappear. I really do prefer telling them, well, this is the consequence of this wide range of vision that we are going to provide you. And patients basically stop complaining because they do not have an expectation. And guess what? When actually this neuroadaptation happens and the halos and the night dysphotopsia fades away, they are even happier. And can you share a time where referring expectations turned into potential dissatisfaction into a success?
When it's just very early presbyopia who wanted to be spectacular independent, I want to encourage the patient that the surgery, we can delay the surgery until the time it will be best profitable for him. And the postoperative care is something what really matters in the patients. Managing with dry eye, as we discussed earlier, can really increase the patient satisfaction and their daily life. And also, if there is some refractive error, it's really good to manage it. What's your best advice for colleagues who want to make simultaneous vision IOLs a predictable, high satisfaction part of the patient's life?
First of all, screen accurately.
Yeah.
Second, under-promise to over-deliver. Third, know your patient. And four, know the IOLs that you're going to implant. Because the mixture in between these points and the validation of these four factors is going to lead to the success or the failure of the choice that we as doctors are making with the patient.
Yeah, and also the setting the examination protocol and the workflow of the patient, especially in higher volume patients, make sense at the clinic.
Thank you very much for joining us for this independent medical education discussion on patients profiling and simultaneous vision IOL selection. We really hope that these insights support you in tailoring lens choices to each individual patient and improving real vision outcomes.
Thank you for the discussion.
Thank you.